Hello everyone, this is Dr. Thomas Abraham, and in this video we're going to talk about the FMG December 2020 anatomy recall questions. And if there is any changes that you want to mention, please comment down below. Let's begin with the first question. It talks about identify the arrow marked structure in the given image. The arrow is right here, as you can see. So let's go straight into the explanation. This is the transverse section of the brain, and where we're going to start with is the internal capsule. You see, internal capsule has an anterior limb, the genu, and the posterior limb. See, the anterior limb of the internal capsule is sandwiched between two structures. One is the head of the caudate nucleus, and the other is this triangular structure that you see here. This is lentiform nucleus. See, lentiform nucleus have two parts. One is putamen, that is outside, and then you have the globus pallidus. Now let's see the posterior limb of the internal capsule. See, the posterior limb of the internal capsule is sandwiched between the lentiform nucleus and the thalamus. So once you know these things, you'll easily solve questions of CT finding. See, the anterior limb of the internal capsule is affixed between the head of the caudate nucleus and the lentiform nucleus. The posterior limb of the internal capsule is affixed between thalamus and the lentiform nucleus. Fine. Now let's look at the CT. Now here in the CT, you see this dark area. This dark area is the internal capsule. Now, as I said, the anterior limb of the internal capsule is sandwiched between head of the caudate nucleus. So see this part. This part is the caudate nucleus. And what is this part? This part is the lentiform nucleus. Now let's look at the posterior limb. See, this is the posterior limb of the internal capsule. You see this V-shaped structure, and right here in the posterior limb of the internal capsule, you can see it is sandwiched between thalamus and what else? The lentiform nucleus. Now let's go back to the question. Now look here. This is the internal capsule. This will be lentiform nucleus. What will be this? This will be caudate nucleus. What will be this? This will be thalamus. So now you know that this arrow is lentiform nucleus. Let's move on to the next question. Nerve involved in the given condition. What is this condition? This condition is known as winging of scapula. Here is a complete representation of the brachial plexus. And in brachial plexus, we can see there are 5 roots. Here is an arrow. You can see long thoracic nerve. See, this long thoracic nerve is formed by the roots of C5, C6 and C7. These are not the terminal nerves. This is arising from the roots of C5, C6 and C7. This is the long thoracic nerve. Now this long thoracic nerve supplies the serratus anterior muscle. Where is the serratus anterior muscle arises from? See, you can see here the serratus anterior is arising from the upper 8 or 9 ribs. And it is inserted onto the medial border of the scapula. So what the serratus anterior does is that it affixes the scapula to the rib cage. So imagine if this muscle is paralyzed because of the injury of the long thoracic nerve, no longer the scapula will be affixed to the rib cage and it will come out like this. And this image that you see here is the winging of scapula. See, the nerve involved in this given condition of winging of scapula is long thoracic nerve. Let's move on to the next question. What is the nerve involved in injury to medial epicondyle of humerus? See, this is the medial epicondyle, and right somewhere here will be the lateral epicondyle. Now let's look into this structure. See, this is the humerus, and here is the medial epicondyle, and here is the lateral epicondyle. See, the ulnar nerve traverses right beneath the medial epicondyle. Below the medial epicondyle, ulnar nerve is passing through. So just in case if the medial epicondyle is injured or fractured, what will happen? There will be injury to the ulnar nerve. And what will be the pathology? There will be ulnar nerve palsy. So the nerve involved in the injury to medial epicondyle of humerus is ulnar nerve. Let's move on to the next question. Now here they have asked the muscle attached to the arrow marked structure. What is this structure? The arrow marked structure, this is lesser trochanter. And where is the greater trochanter? Greater trochanter is here. Let's look at an image. See right here. This is the greater trochanter and this is the lesser trochanter. See, there is only one muscle. The muscle name is iliopsoas. Iliopsoas is a combination of iliacus muscle and the psoas muscle. See, the psoas muscle, psoas major and minor muscle arises from the vertebra, and the iliacus muscle arises from the iliac crest, and they insert onto the lesser trochanter. This is the lesser trochanter. Now come to the right side. You see the iliopsoas insertion. Here is the lesser trochanter that you saw in X-ray, and this is the greater trochanter. So on the lesser trochanter, the iliopsoas muscle is inserted. So now let's look in the question. The answer will be iliopsoas. The muscle attached to the lesser trochanter is iliopsoas. Let's move on to the next question. Identify the marked joint in the given image. What is this joint called? This is pubic symphysis. And now let's look at the types of joint, and then eventually we come to the conclusion of the answer. Alright. Now here we have two kinds of joints in the body. One is solid joint and the other one is synovial joint. Now here we are looking at the solid joint because the question is asked about it, so I'm not going into much details of the synovial joint. Let's look at the solid joint. Solid joints are of two types, fibrous joint and the cartilaginous joint. So let's look at the fibrous joints. We have sutures, gomphosis, syndesmosis, and then you have the cartilaginous joints, which are synchondrosis, which is also known as primary cartilaginous joints, and then you have the symphysis. These symphysis are secondary cartilaginous joints. Cartilaginous joints are joints which are uniting the bones by cartilage. We have two types. One is the primary cartilaginous joint, which is also known as synchondrosis, and the second one is secondary cartilaginous joints. See, the difference between primary and secondary is primary is united by hyaline cartilage and secondary is united by fibrocartilage. See, the examples of primary cartilaginous joints are epiphyseal plate and the first sternocostal joint. Then the examples of secondary cartilaginous joints are intervertebral disc between the vertebrae, and then you have the pubic symphysis, and you have manubriosternal joint. Pubic symphysis is a cartilaginous joint, and what type of cartilaginous joint? It is a secondary cartilaginous joint. Now let's move on to the next question. Identify the arrow marked tarsal bone in the given image. Now let's look into the image. Tibia sits on the talus, and in front of talus there is navicular, and then you have cuboid, and then you have three cuneiforms. Then you have the metatarsals, and then you have phalanges. Now looking into the X-ray, you see the tibia sitting on the talus, and right in front of talus you have the navicular bone, and then you have the cuboid bone laterally, and medially you have the cuneiform, and then you have the metatarsals and phalanges. What will be the answer? Answer will be navicular bone. See, this is the navicular bone, this is the talus bone, this is the calcaneus, and then you have the cuboidal. On the medial side you have the cuneiform, and then you have the metatarsals, right? So the answer will be navicular. Which nerve injury causes difficulty in eversion of the foot and loss of sensation in dorsal aspect of the foot? Now let's look into the common peroneal nerve will divide into superficial fibular nerve and the deep fibular nerve. See, the superficial fibular nerve will innervate the lateral compartment of the leg. Lateral compartment of the leg, you see this is the lateral compartment, lateral side, and the lateral compartment of the leg, what it will do eversion. What are these muscles? Fibularis longus and fibularis brevis. These are the lateral compartment muscles. So superficial fibular nerve will help in eversion. And the deep fibular nerve will supply the anterior compartment of leg. See, if it supplies the anterior compartment of leg, what it will do? Anterior compartment of leg, it will do dorsiflexion and it will do inversion. So deep fibular nerve is doing inversion, superficial fibular nerve is doing eversion. Now they have already also mentioned that the dorsum of the foot, you see the dorsum of the foot, on the dorsal aspect of the foot there is loss of sensation, right? Now let's see the dorsal aspect of the foot. This is the dorsal aspect of the foot. See, dorsal aspect of the foot is supplied by superficial fibular nerve. See, dorsal aspect of the foot is supplied by superficial fibular nerve except for the first web space. See the first digit web space. See, this is supplied by deep fibular nerve. Alright. So what would be the answer? It will be superficial fibular nerve or superficial peroneal nerve. Both are same. So if there is any injury to this nerve, there will be difficulty in eversion and there will be loss of sensation in the dorsum of the foot. If there is deep peroneal nerve is involved, then you won't be able to do inversion. Superficial is eversion. Okay. Now let's look at the question number 8. What is the structure marked in the image? See, what is this going? this green color, this is the thoracic duct, right? And where it will drain into, let's look into it. See, two things you have to remember when you study about the lymphatic drainage of the body. See, right half of the body above the diaphragm, this is the right half of the body. Right half of the body above the diaphragm, that is the right side of the head and neck, right side of thorax and the right upper limb, will eventually drain into right lymphatic duct. And the right lymphatic duct will eventually drain into right jugulo-subclavian vein angle. You see, this is the jugular vein coming and this is the subclavian vein coming. Right at this angle, the right lymphatic duct drains into it. Now let's look at the other side. See, all the rest of the body, except for the right half of the body above the diaphragm, is drained by thoracic duct. See, this is the thoracic duct going upwards, and right at the left jugulo-subclavian venous angle, the thoracic duct will drain. Alright, so the thoracic duct will eventually drain into where? The left jugular vein and the subclavian vein angle. So right here, okay? So now what will be the option? The option will be the junction of the left jugular vein and subclavian vein. You see the thoracic duct coming and it will eventually drain here, right here, at the junction of the left jugular vein and the left subclavian vein. Fine. Let's move on to the next question. The tendon marked X in the given images. The tendon marked X in the given images. Let's see at the complete description. You see here the tendon of the flexor carpi radialis. Here you see the flexor digitorum superficialis tendon, and here is the flexor carpi ulnaris. Now it was much easier if you would have just remembered the radialis is on the radial side and the ulnaris is on the ulnar side, and the flexor digitorum superficialis is in between them. So you know that this is flexor carpi radialis. Now one more thing that I want you to know, this has not come in the exam, but it is very important. See, all the muscles of the anterior compartment of the forearm, the anterior compartment of the forearm, all the muscles are innervated by median nerve, except for two muscles. This is very important. This has been asked in many exams, and these are flexor carpi ulnaris muscle and the ulnar half of the flexor digitorum profundus, which is innervated by ulnar nerve. So this is the exception. See, all the muscles of the anterior compartment of the forearm is supplied by median nerve, except for the flexor carpi ulnaris and the ulnar half of the flexor digitorum profundus, which is innervated by ulnar nerve. Fine. So what will be the answer of this? This is the radial side. Right at the radial side you have the flexor carpi radialis. At the ulnar side you have the flexor carpi ulnaris, and in between them you have the flexor digitorum superficialis. Fine. So this is the answer. Let's move on to the last question. Tingling sensation and paresthesia on medial side of the hand. Which structure is most likely affected? See, there is tingling sensation and paresthesias. See, if there is tingling sensation and paresthesia, there has to be some nerve involvement there. And on the medial side of the hand, which nerve will be supplying the medial side of the hand? It is ulnar nerve, and there has to be some ulnar nerve injury. So let's look into this image. See, A is brachial plexus. See, ulnar nerve is a branch of brachial plexus, right? Ulnar nerve arises is the terminal branch of brachial plexus, right? So if the ulnar nerve is injured, there will be tingling sensation and paresthesia. So what will be the answer? The answer will be A. Let's look here. See, this is the brachial plexus. Brachial plexus is injured. There will be tingling and paresthesias on the medial side of the hand. And there will be ulnar claw hand deformity. That is also there. So this has to be brachial plexus. The answer is A, brachial plexus. Fine. Well, thank you for watching. And if there is any extra question that you want to tell me, you can either text me in our Telegram group. The link to the Telegram group is in the description below. And also don't forget to subscribe and stay tuned, many more videos are coming. Thank you.